and welcome to Medical Shorts by Tutor IMG. In this video, I'm going to discuss about the management of the rheumatoid arthritis. So the rheumatoid arthritis is a chronic inflammatory disease. It begins in the small joint of hands and feet, cause pain, swelling, and stiffness. It can affect other body part and system as well. So the key is early diagnosis and intervention with DMARDs. Early treatment within first 3 months of disease will allow better control and remission. So we start with a non-pharmacological intervention first. Patient education, psychosocial intervention, exercise, physical therapy, occupational therapy, nutritional and dietary counseling, interventions to reduce the risk of cardiovascular disease include smoking cessation and lipid control. Immunization to decrease the risk of the infectious complication of immunosuppressive therapy. So starting with the pharmacological therapy, so prior to starting with the pharmacological therapy with DMARDs, we need to obtain baseline testing which include CBC, serum creatinine, aminotransferases, ESR, serum reactive protein, hepatitis B serology, hepatitis C serology in those patients who are at high risk. If you're planning to prescribe the patient with hydrochloroquine, you need to perform ophthalmological screening as well. Chest X-ray, especially before prescribing methotrexate, and the testing for latent tuberculosis. So we need to perform these baseline testing before starting treatment with DMARDs. The gold standard is methotrexate. So basically, you need to follow up the patient every 3 months. If there is inadequate response in 3 to 6 months, you can change methotrexate with other DMARDs, or you can add another medication with methotrexate. The other DMARDs which we can use include leflunomide, we have hydrochloroquine, and we have sulfasalazine. If the patient has contraindication to methotrexate, you can use any of these medication, leflunomide, hydrochloroquine, sulfasalazine. If the patient has high disease activity and the poor prognostic factor, you can give the patient combination of methotrexate with any of these DMARDs. We can also use NSAIDs and steroid for the symptomatic control of the pain and inflammation, and they can be used as a bridging therapy as well because DMARD takes time to start kicking in. But you cannot use steroid for a longer period of time because of the number of the side effect that is associated with the use of steroid. If the patient does not improve on methotrexate and other DMARDs, then we use BDMARDs, which is known as biologics. The most common biologics are infliximab, etanercept, and we have certolizumab. So you can use infliximab, etanercept, or certolizumab if the patient has inadequate response to methotrexate and other DMRDs. So these are basically the biologics. You need to follow up the patient every 3 to 6 months. And once the inflammation has been settled down, you can follow up the patient every 6 to 12 months. So that is all about the treatment of rheumatoid arthritis. If you like this video, kindly subscribe to our channel, Tutor IMG, and press the bell icon to receive all the notification about our latest videos. Thank you very much.